Hello, I am Dr. Saif, a critical care physician and teacher, and today's topic is autoimmune encephalitis, a leading cause of treatable coma and relentless seizures, refractory seizures in young adults. Now, autoimmune encephalitis is becoming as common as viral encephalitis. It is a severe inflammatory brain disease requiring intensive care due to its rapid and progressive nature and complications because of this, where the body's immune response is going to attack on the brain, and that is why it is important for us to know about its diagnosis, how we make it, and the treatment. To maintain the engaging discussion, we will analyze the case, identifying common clinical symptoms and signs, and we will also know appropriate investigations to exclude other causes of encephalopathy and confirm autoimmune encephalitis, and review the case management alongside standard treatment approaches as per guidelines. So, we had a patient in our ICU who was a previously healthy lady, a 28-year-old homemaker, who presented with a month of prodrome of headache, intermittent headache, mild fever, and fatigue. Over the last 1 week, her symptoms acutely progressed to include altered mental status with persistent feeling of threat, agitation, and short-term memory loss. Following a witnessed seizures, she was brought to the emergency department by her husband. On admission, she was post-ictal, unresponsive, and she required immediate ICU admission because of poor GCS. At presentation to emergency, her vital signs were otherwise stable, but she had mild tachycardia and fluctuating blood pressure, and her GCS was E3V2M4. She was disoriented, nonverbal, and she had brisk reflexes. She showed no focal neurological deficits. Episodes of agitation alternated with the periods of mutism. So was her clinical presentation. Now, clinicians should recognize the typical rapid encephalopathy seen in these cases, which progresses from onset to coma within days to weeks. It is quite progressive and fast. Some patients may present first with refractory status epilepticus or frequent fatiobrachial dystonic seizures, that is brief unilateral muscle contraction over the face and the arm. So these fatiobrachial dystonic seizures are hallmark of autoimmune encephalitis caused by LGI1 antibodies, and LGI1 is a protein involved in synaptic function, and its disruption by these antibodies interferes with the normal intersynaptic protein interactions, and that is how it can cause limbic encephalitis. So patients may exhibit significant autonomic instability also, which can include hyperthermia, tachycardia, hypertension, or bradycardia. Along with this, sometimes various movement disorders may also be observed, such as orofacial dyskinesia, chorea, or rigidity. So the symptoms could be mixed. If presentation is delayed, brainstem involvement may occur, manifesting as central hypoventilation that requires intubation and mechanical ventilation immediately. Some patients, as illustrated by our case, can present primarily with diverse psychiatric symptoms, as we see in our case also: agitation, psychosis, mutism, catatonia, all may precede the onset of coma. The final outcome, final pathway which is there is the coma. Recognizing these clinical patterns is essential because it is going to lead to early treatment and can delay the onset of complications and decrease the ICU stay. On day 1, this patient was intubated due to low Glasgow Coma Scale and a post-ictal state. To manage seizures, we started levetiracetam, which was administered as loading dose and continued as the maintenance therapy. Intravenous acyclovir was also initiated because we were suspecting HSV encephalitis. and we sent LP, the CSF. So, and we were planning for MRI. So the basic labs and imaging were done. Okay. CSF demonstrated mild lymphocytic pleocytosis, so lymphocytes were higher, more than 5, elevated protein and normal glucose levels. The CSF panel showed no HSV virus and no herpes simplex virus, and brain CT was normal, while brain MRI revealed hyperintensities in the medial temporal lobes bilaterally, which was consistent with the features of limbic encephalitis. So diagnosis as per MRI was limbic encephalitis. When we performed EEG, it showed diffuse slowing of frontal delta activity, findings which may be observed in cases of encephalitis. The collective results were suggestive of possible diagnosis of limbic encephalitis as per MRI. And as you know, the limbic system comprises the complex network of brain structures responsible for regulation of memories, emotions, motivation, and behavior. In this patient, we saw the behavioral changes, cognitive symptoms, psychiatric symptoms, seizures, autonomic stability, so all suggest autoimmune encephalitis. However, we didn't have antibody, and we started treatment, the suppressive treatment. Finally, the CSF antibody panel came positive for anti and MDA receptor antibodies. Both the paraneoplastic panel and pelvic ultrasound were negative. We tested for tumors because paraneoplastic encephalitis, a type of autoimmune encephalitis, can result from immune system reacting to certain cancers like lung, ovary, breast, or testicular cancer. So now at this point, it is appropriate to review the essential test for diagnosis of encephalitis. So it is important to recognize mimics or differential diagnosis in this case. Very important, so that we can exclude all of them one by one based on our clinical presentation and the investigations. Okay, so it is very important. So differential diagnosis include the first and foremost is the herpes simplex. So herpes simplex virus encephalitis should be considered first. It usually presents abruptly with fever, seizures, and focal neurological signs, especially temporal lobe involvement on MRI. In contrast, autoimmune encephalitis often develops gradually compared to HSV encephalitis, and it also involves behavioral changes as we have seen in this case, and abnormal movements, and most likely an MRI hippocampal region is involved, the limbic region on MRI. Other central nervous system infections also can present similarly, like tuberculosis, HIV, syphilis, fungal. There could be non-convulsive status epilepticus, which can have similar presentation, paraneoplastic syndromes, CNS neoplasms, glioma, lymphoma, etc., and multiple sclerosis, CNS vasculitis, Wernicke's encephalopathy. So all these could be, the differential. Even Hashimoto's thyroiditis also, which is the autoimmune thyroiditis and thyroidopathy, and Hashimoto's encephalopathy is also there, caused by the same mechanism. So clinicians should conduct thorough investigation to differentiate all these possibilities when assessing the suspected case of autoimmune encephalitis, okay, or any kind of encephalitis. So now let's discuss the role of CSF. So coming to the role of CSF analysis in autoimmune encephalitis, it is important because the results can change depending upon how advanced the illness is. And having a moderate number of lymphocytes in the CSF, say more than 5, is a sign of illness, but this might not be present later on. So it is present early. Lymphocytic predominance or lymphocytic pleocytosis can be present early but not late in the course of illness. So you may find negative CSF completely, and it is not going to put so much of light on the diagnostic certainty. This is why MRI is very important. So brain MRI is very important for diagnosis of autoimmune encephalitis. MRI can appear normal at the beginning of illness again. So in the earlier, CSF will be abnormal, but MRI will be normal. Okay, in about 75% cases, early MRI will be negative. Despite this, there might be bright areas on MRI in both temporal lobes, that is called flare hyperintensities, which is seen more predominantly and more commonly in later stage of diseases. Now regarding the EEG can vary different type of autoimmune encephalitis. Common EEG findings include generalized or localized slowing of brain activities, irregular background activity, or sometimes brief burst of rhythmic activity, that is called BIRD, extreme delta brush EDB, which is a specific pattern of delta waves with burst of beat activity on the top of them. It is very specific to NT and MDR encephalitis, so which is the type of encephalitis, of course. So again, now coming to autoimmune panel. So we have an MDAR, we have LGI1, we have Casper, GABA, all these antibody, even AMPR, AMPAR antibody, MOG antibodies. Okay, so this is antibiotic panel which has to be done on serum and in CSF. So CSF is more important because CSF enhances the specificity. So if you do CSF autoantibody and it is positive, it is more specific for the disease autoimmune encephalitis. Apart from that, we should do malignancy screening for the prognosis, and that is how onconeural workup comes into existence in our diagnostic workup. So this workup is essential in autoimmune encephalitis, especially when antibodies target intracellular antigens like anti-WHO, YO, RI, etc., which are strongly associated with paraneoplastic syndromes. Detecting an underlying tumor, commonly ovarian, teratoma, thymoma, or small cell lung cancer, can guide both immunotherapy and oncological treatment by an oncologist. Even surface antigen antibodies like an MDA or AMPAR may have paraneoplastic links, so you should aim for comprehensive screening of these tumors using CT, chest, abdomen, or pelvis, pelvic ultrasound if CT is not possible, or if time permits you, if the patient is stable, you can go for whole body PET scan. So this surveillance is very important. Remember that this is just a imaging surveillance, but it is important to know that this can miss small tumor again and again. You need a follow-up. Now we will talk about the criteria, clinical criteria. So there is a 2016 gross Damau criteria which categorize autoimmune encephalitis into possible, probable, or definite based on clinical presentation, MRI, EEG, CSF analysis, and antibody identification. These criteria aid in distinguishing autoimmune encephalitis from other conditions, making prompt immunotherapy possible so that we can initiate early and prevent the misdiagnosis, okay, and achieve a good outcome. Now back to our case. So further, this patient received multifaceted immunotherapy. So we started with first line immunosuppressive therapy, that is IV methylprednisolone 1 gram per day for 5 days. Then patient received IVIG and plasmapheresis 5 sessions, and patient did not respond to these 3 immunosuppressive therapies. So we went for even rituximab, and after rituximab, patient showed some improvement. So generally in such cases, what we do, we start high dose corticosteroids, and also along with that IVIG or plasma exchange. And for the refractory cases, second line agents such as rituximab or cyclophosphamide can be very useful. And symptomatic management involves antiepileptics for seizures, mechanical ventilation for respiratory failure, and cardiovascular support for autonomic instability. Initially, the patient experienced the continued agitation and autonomic instability, requiring sedation with dexmedetomidine, the Presidex, and intermittent midazolam infusions. EG showed persistent encephalopathy without status epilepticus, so there was bus suppression. During the second week, the patient gradually improved in responsiveness and was extubated on day 12. So rituximab helped. Psychiatric symptoms persisted but less intense. By week 3 and 4, the patient was transferred to a step-down unit. He started on neurorehabilitation and psychiatric support and showed consistent slow improvement in memory and cognition. And patient was eventually discharged to home with outpatient follow-up after that and continuation of rituximab. So this was whole case scenario. Now remember, delayed treatment can lead to severe complications, including superrefractory status epilepticus, autonomic dysfunction, and prolonged ventilation, posing inherent challenges to the ICU team. So this is why we need to start the treatment early, because 80% of autoimmune encephalitis patients recover well with the early treatment. However, delayed diagnosis, misdiagnosis increases the risk of long-term cognitive and behavioral deficits. Okay, so this is about the morbidity, and regarding the mortality, it is about 4%, and the recurrence rate is about 10%. So these are the figures, numbers. Several misconceptions are there in autoimmune encephalitis, which consider discussion. So remember that in up to 20% of misdiagnosed cases, we have non-specific antibodies without meeting diagnostic criteria. That is why clinical context, CSF analysis, MRI, EEG, everything is crucial, because in 30% cases, cognitive decline, movement disorders, sleep disturbances may be seen, not just seizure or psychosis. Okay, and MRI and CSF may be normal in up to 40% of early cases, and even antibodies will not be possibly showed up in CSF. The notion that it is extremely rare is outdated. Recent studies indicate that incidence is increasing and as good as the infectious encephalitis. Now the notion that only young women get this, it is actually misleading. Initially described in this population, but anti-NMDR encephalitis affects all ages, all sexes, both sexes, and tumor association is present only in 40% of adult females, even less in males and children. The disease manifests with psychiatric symptoms, seizures, and movement disorder, often leading to misdiagnosis of primary. Okay. Now, statement that antibody negative autoimmune encephalitis doesn't exist is again a myth. Seronegative autoimmune encephalitis can occur in up to 50% of diagnosed cases. Okay, so this is very huge number, 50%. Half of the patients of autoimmune encephalitis may have seronegativity, and this is very important fact, because we should not wait for autoantibodies result to start the immunotherapy. Okay, so this is very important. We should start immunotherapy just on the basis of suspicion. EEG, MRI, CSF show something, definitely we should start. But A is not a diagnosis of exclusion. Okay, not always. It is better to exclude infectious, metabolic, structural causes, but new onset psychosis, seizures, rapid cognitive decline is equally critical for early presumptive diagnosis. Okay. Finally, A is always paraneoplastic is also incorrect, because we know there are some subtypes like anti-WHO, anti-MA2. These autoimmune encephalitis are strongly linked to malignancy, and many are idiopathic or post-infectious. Anti-NMDR encephalitis is paraneoplastic in only 40% of adult women and less than 10% in children. So not all the cases are, paraneoplastic. And post-herpetic anti-NMDAR is increasingly recognized after HSV encephalitis. So in summary, suspect autoimmune encephalitis based on clinical background in the patients with rapid neuropsychiatric decline, particularly after excluding infectious, metabolic, and structural etiologies. Over 60% of these patients present with psychiatric or cognitive symptoms, often leading to initial misdiagnosis. okay, and mistreatment. And early immunotherapy and improves outcome. Do not wait for antibody confirmation. A retrospective study demonstrated significantly greater improvement in the case scores at 6 and 12 months in patients treated with 90 days of symptom onset. So if you start treatment early, you will have very good outcome. And utilize EEG and MRI proactively, even with initial normal imaging. In a large cohort, 39% had MRI normal, especially in anti and MDAR encephalitis. So even MRI could be normal, okay? And limbic system abnormalities were present in 33% of cases. All right. So our last thing is multidisciplinary ICU care, which is the backbone of treatment in case of autoimmune encephalitis. You should involve neurologist, infectious disease consultants, rheumatologist, and obviously the critical care physician. Everybody, every department is important to manage such cases. So managing autoimmune encephalitis is in critical care is a very good topic, and I have taken the references from this very good paper published in uh, Europe, PMC in the PubMed by Diaz, Arias, Pardo, and Probasco. And also, you should just give a good reading to an article by Ligoi, Carventis, and Sonevli in current opinion critical care, okay, which summarizes information on autoimmune encephalitis. So that's all for today on autoimmune encephalitis. I hope this video will be appreciated by you. Don't forget to like, share, and subscribe to my channel and my other channels also. And let me know what you liked about this video. I will come again with new video. Thank you so much.